Now, does that mean that in the future we won't find some benefit in this? I think we probably.
The future is here. Everybody, I'm Dr. Matt Dawson. I'm the founder of a company called Wild Health. Wild Health, we've seen thousands of patients, and we practice what we call precision medicine. So we sequence everyone's DNA. We look at DNA methylation, epigenetic testing, really deep biomarker testing, kind of all your common biomarkers plus wearable data. And then we bring all that data together to give precision medicine recommendations. More recently, I'm also the CEO of a company that does epigenetic and DNA methylation testing called True Diagnostic. Now, clinically, in my company, Wild Health, we had used this DNA methylation and epigenetic age testing for our patients. So I'm familiar with the science, but I went really deep into the science in the last year. And recently I was watching a video by Dr. Andrew Huberman and Dr. Peter Attia where they started talking about biologic age tests. Now, I was watching the episode because it was an episode on longevity. And anytime I see these two talk, especially on something like longevity, I'm going to watch because I'm going to learn things. They're both brilliant. They both make great points. But when they started talking about this one specific area, the vast majority of what they said was accurate. I just felt it was very incomplete. And there were some inaccuracies as well, which I'll call out. But I want to go over that video with you and tell you where I think there needs to be more nuance added to the discussion.
This is my opportunity to ask about your belief or lack of belief in biological aging tests. Okay,
so real quick, Dr. Huberman, one of my favorites. However, I have a little bit of issue with even how he asked the question. He asked about belief and non-belief. I'd rather that he asks about what is the evidence or lack of evidence for biologic age tests. And both of these guys are deep in the evidence. So I think I'm going to just assume that when Peter's talking about his belief or non-belief, he's talking about evidence versus not. Just a slight issue I have there with the question. But love you, Dr. Huberman. I think you're great. So just wanted to point out that.
Because if somebody's going to experiment with any or all of these things, they may want to evaluate whether or not their biological age is changing. And there are a number of these tests available. Mm-hmm. And people love this stuff.
Love them.
They love them. I mean, who wouldn't want to see that they are 51 years old, but their biological age is 37?
I just did a movement test the other day. So it's a very fancy camera system where it's got 1 million cameras on you, and you go through this whole exercise. How high can you jump? How far can you throw? Like, it was awesome. And then it gives you a movement age. Andrew, I was 22.
I believe it.
I mean, I should feel amazing. Do you actually think I move like a 22-year-old? I mean, are you freaking kidding me? I bet you if I went and did that again tomorrow, I'd come back at 31 or something.
All right, so I think Peter probably does move like a 22-year-old. I've seen his workout routines, but he's making a great point here. The point is there has to be precision with these tests. If you take the same test the next day, like Peter talks about, or the same day, it can't be off that much. And with the early first-generation biologic clocks, that was the case. Some of the data on this, some of the earlier clocks, if you take the same test the same day, the same person, it may come back with a 4-year difference. That's not useful. As a clinician, I want to know if an intervention or what we're doing actually has an effect. And if I test and then a year later I test and they're 3 years younger or 3 years older, that's meaningless because the standard error is 4 years. So it tells you nothing. So it's a great point. There has to be precision with these tests.
There is so much nonsense in this type of testing.
Okay, another great point. I would say with the biologic age tests, 95% of what's out there is meaningless and it's trash. The issue I would have here, though, is to use kind of some analogies. He's using the movement analogies. I think the analogies are helpful. If Andrew was to ask, hey, Peter, what do you think about drinking liquids? And Peter says, look, do you know what happens to your body if you drink a Coke, like the spike in glucose, the spike in insulin, what that does to your body? So no, you definitely shouldn't. We're talking about liquids, not just one liquid. So it's a lot different if you're drinking water. And to use a less hyperbolic example, take something like lipids. We said, what about lipid testing? And Peter would say, total cholesterol is meaningless. It just doesn't help me make decisions. He wouldn't say that. He would talk about how lipid fractionation probably is helpful, or ApoB. Just because something in the past didn't work, we get better versions of it as we go. Same thing as CT scanner. Is a CT scanner useful? Well, no, they're not useful. You just get 4 slices. We can't really tell with precision what's going on. Well, no, there used to be 4 slice CTs. Now we have much better ones with much better resolution. So I want a nuanced discussion of the biologic age test. Is there so much trash in the field? Yeah, 95%. But let's maybe talk about the 5% that works. Sorry to interrupt.
It is just, look, there's probably something to be said if I do that and I come out at 22 as I did versus 92.
Sure.
I would grant you that if you took 150-year-olds and you put them through a movement test, the ones that really, really are struggling will come out older, and the ones that really, really are doing great are going to come out younger. So great. I guess it's not. I guess I move reasonably well for a 51-year-old.
So he's really using the cholesterol analogy. So even if you use to say cholesterol, total cholesterol itself isn't good. If you get total cholesterol of 150 versus 1,000, there's probably something there. So that's the analogy he's using. But again, we should be talking about ApoB specifically, or lipid fractionation in a more sophisticated way. So the kind of straw man argument there, showing a bad test, doesn't work. We need to do a little more than that.
It's simply impossible to believe that I can do today what I could do when I was 22 with respect to movement and strength and power, which is what that was assessing. You're doing a lot of jumping, single leg jump here, do all this kind of stuff, balance testing, all sorts of things. And I guess I would say the gold standard for any of these biologic aging tests has to be the following. What is a better predictor of remaining years of life? Chronologic age or biologic age?
Okay, so I would agree that's important. I think there's other things that are important as well. Like we mentioned, and like Peter alluded to, but he didn't really come out and say it, the precision. Is the variability test to test, is it tight enough that what we're seeing as changing, that's actually from an effect, not just standard error? So does it predict the remaining years of life? Is there precision? And how does it correlate to actual disease risk? We know the number one risk for all chronic disease is age. So these biologic age tests should tell us risk for disease as well. So I would put a much higher bar as to are these useful or not. Peter's setting a pretty low bar here, so I think he's going to talk more about that low bar.
That's, to me, the most important standard. So how old are you chronologically?
I turned 49 in 6 weeks.
Okay. So I'm sure your listeners will not like to hear this because they would probably hope and believe that you are immortal, but
some might want to hear that I'm going to be taken out soon.
That's not true, Andrew. We all love you.
But let's just grant your mortality as a given. Based just on your chronologic age, an actuary would come up with a pretty decent prediction of how long you're going to live. Now, I would argue that that's a crude assumption because it doesn't take into account the fact that you're metabolically healthy, that you do all of the things that you do. But just based on the fact that you are a man who is 49 years old and who doesn't smoke, those three things would give me...
Okay, so it is a crude assumption. And one of my responses to that would be, there are tests that are trained to be more accurate than your chronologic age. There are very specific ones. We should look at the science and evidence around GRIM-Age2, around the omic image. This is a test developed by Harvard and just published on in the last year, and DunedinPACE from Duke. So those tests very specifically are trained to predict the remaining lifespan. So let's talk more about it.
A very good prediction of your life expectancy. And because I'm not an actuary, I don't know the exact number, but my guess is it would be predicted at this point at another 37 years.
Okay. Well, I bought that chart, My Life in Weeks.
Yes.
In fact, I bought two of them for reasons that are uninteresting. But
hold on, I think that's very interesting. I'm really curious as to why you bought two. I think you need to do a follow-up and tell us why.
That chart, Phil, not quite what you predicted, but I put my estimated lifespan to be 95.
I just want to make this point about the actuarial point, right? So let's just say actuarially your expectation is 40 years more at this point because you're 49, you're a male, and you don't smoke. So we believe you have somewhere between 35 and 40 more years of life predicted on the basis of your biologic age.
That's it? That's all I got?
You're going to live to whatever, 88 to 91 or something. I'm making that up, but that's like, okay.
I better get cracking on some stuff.
So now let's pretend you went and did a biologic age test. Okay. So let's say you did that. And let's say it came back and said you're 25.
Okay, so 3 points here. Number one, I want to know what Andrew just wrote down that he's got to get cracking on. Number two, I am cognizant of how ridiculous it is for me to be inserting myself into a conversation between two people where I wasn't invited, but hey, I'm here, so I'm going to make some more points. The third point I want to make right now is Peter just said, imagine you get a test back that says you're biologically 25 when you're chronologically 49. Okay, so to go back to our, he's saying, imagine you get a ridiculous result back. Are you going to believe that? Of course, you're not going to believe that. I mentioned something called a straw man argument earlier. He's making it again here, making up an imaginary test and saying, now you've got a ridiculous result. Should you trust this? No, you should never trust ridiculous results. If you measure your triglycerides, like he mentioned earlier, and you get a result of 2, should you trust it? No, that's a ridiculous result. There's a lab error. There's something else going on. So to make up a result, and again, there are biologic age tests that come back with this result. So he's using a real example, but if there are 100 biologic age tests, he's using a really bad one to say, don't trust biologic age tests. No, let's have a more nuanced discussion. Let's talk about the ones that give you that kind of result, and let's talk about the ones that are giving good results, like 𝗪𝗵𝘁 developed by Harvard, the Duke DunedinPACE one. Andrew and Peter had a great nuanced discussion earlier in this video about NR versus NAD versus NMN. I want the same kind of nuanced discussion around the different biologic age tests and what's available right now, not this kind of argument of, if you get a ridiculous result, that means these tests aren't any good. That's true for any test, but some of them give you good results.
So if I had a 25-year-old male non-smoker in front of me, what's his life expectancy? Well, it's about 60 to 65 years. Does that mean that you, Andrew, have 60 to 65 more years of life based on a fact that your biologic clock says you're 25? Do you believe that?
No way.
No, it doesn't, because that's a bad biologic age clock. So point making, don't use bad biologic age clocks.
No, of course not. Now, this would be an easy thing to test, not in humans, but you could do it in mice, right? Interesting that, to my knowledge, that experiment hasn't been done. So right out of the gate, when I look at people talking about their biologic age, well, I'm actually 60 years old, chronologically, but my biologic age is 35. My response is, who cares?
100%. I see people post about this all the time. They'll say they're 60 and their biologic age is 35. No, they're using a junk biologic age test. If you see that result, it's not a good test, period. 100% agree with you, Peter.
Truthfully, is that a good thing? Yes, probably. But is it tangibly, measurably meaningful? Like to have a biologic age of 35 versus 40 versus 30 if you're 60? I don't think, I think we're applying a very false level of precision to something that might only need to be directionally true. Secondly, we don't really yet understand the biologic noise in that measurement, right? So there are lots of things that we measure that are really noisy. So if I measured your, I don't know, let's think of something that's very biologically noisy, your triglyceride level. Like your triglycerides are pretty noisy unless I do something very important, which is standardize it by how long it's been since your last meal. Like if you ask me right now what my trigs are, I have no earthly idea because, I probably ate 3 hours ago. And I don't even remember what I ate, how much fat was in it, how much carbohydrate was in it. I have no idea. So the only way you could really get a triglyceride measurement and put any weight to it is if you've been fasting for 8 to 12 hours. Then we can at least say, hey, a triglyceride level of 50 milligrams per deciliter is excellent, whereas a triglyceride level of 120 milligrams per deciliter is lousy. But if you measured my trigs today and they were meeting at this moment and they were 150, that could be totally reasonable, even though at fasting levels I'm at 50. So we know that because we know exactly what goes into the triglyceride measurement. But when you look at a biologic clock that takes into account your glucose.
Okay, so Peter's saying there's a lot of noise to go into these tests. So again, just making the point, I would prefer more precision here. There are dozens of tests. Which tests are we talking about that have all the biologic noise? So I think he's going to cover that.
To account your glucose level, your vitamin D level, your epigenetic marker here or there.
Okay, so thanks. That clears it up. So there are so many different folks are putting out all the time these algorithms for biologic age based on multiple different things. So Peter's talking about one that actually takes into account things like vitamin D and I think he said glucose and epigenetic markers. Yeah, there's a lot of noise in that. And that's a great and fair point about those clocks. However, again, the point I'll keep making is there are newer and better clocks that don't have all of that noise. And hopefully he's going to get to that soon.
Those are very noisy things. So how do I know when I measure it in you now versus when I measure it in you a year from now, I captured you in the exact same space? I mean, I don't.
So I'll tell you how you can know that. As you can do the study, you can draw the same test from the same person when they're in the same state. Maybe you do it at the same time, maybe you do it the next day, and measure the variation, the precision. For example, the DunedinPACE, which I mentioned out of Duke, it's got a really tight interclass correlation. So anytime you measure any test, there's going to be some variation test to test. Is it from a biologic effect, which you hope, or is it from standard error? And we talked about this a little bit earlier when I said some of the early clocks had a 4-year difference. So even if the triglycerides or any other test that you're going to measure, if you pull it the same person, the same time, and run it on 2 different machines, or even the same machine, you're going to get slightly different results, but it may be just 2 to 3% different. So even the triglyceride, if you measure it 1 year, one time, and then a year later, and it's a 3% up or down, you're not going to say that's an improvement or that's worse because you know that's within the standard error. So you can do it. You can test these clocks, and you can see if you get wildly different results the same day on the same person, there's too much error there. But this has been done with different clocks to measure how tight that is, so that is it an actual biologic difference or is it just noise? Is it just standard error? That applies to every biomarker. Again, we have to look at different biologic age clocks and which ones are tight enough and which ones aren't.
So it's for that reason that I just have a very hard time putting any stock in this. Now, does that mean that in the future we won't find some benefit in this? I think we probably.
The future is here. So when I hear Peter talk about this, so Peter he put out a newsletter about a year ago on these biologic age clocks. And when I read it, my conclusion for that was, this is very accurate with data from a year or two ago, but there's new stuff out. And I think what's going on is Peter's talking about his feelings on this based on all the evidence that is mined that is not completely up to date. Some about the future. The future is here. The 𝗪𝗶𝘁 that I talked about out of Harvard, that's just been in the last year. The DunedinPACE, it's a newer one as well. It's not these older clocks. So I would say the future is here. I'd love to have a nuanced discussion with Dr. 𝗪𝗵 or Dr. Attia about the newer clocks that actually do have some usefulness and validity.
I think we probably will. I do think of all the things that go into it, probably the epigenetic part of it would be the most interesting.
That's exactly right. So the clocks that I've called out by name, like the 𝗪𝗵𝘁 and the PACE, it is purely epigenetics, DNA methylation, looking at specific CPG sites. It doesn't have a lot of the other noise. Those are the types of clocks that are useful. So we're on the exact same page. And I think Peter did a podcast before on epigenetics and DNA methylation testing in general, and that is where the money is at when it comes to biologic age testing and pace of aging.
But again, what most people don't understand is sort of a dirty little secret is how difficult it is to measure and to sequence the epigenome, right? So to my knowledge, none of the companies that are doing this, I may be incorrect on this, by the way, but the last time I looked, which was about a year ago, not a single company was correctly sequenced.
Okay, so this is where there's a clear inaccuracy that needs to be corrected. So to Peter's credit, he's a humble person in general. He said, to my knowledge, and the last time I looked. So True Diagnostic, the company that I mentioned, this is exactly what we do. We look at epigenetics, and it is not difficult to accurately sequence the epigenome. We look at about 900,000 specific CPG sites and get beta values on how hyper or hypomethylated each one of these is. It is being done exactly that way.
sequencing the epigenome on these things. So they were not able to accurately say what they were giving you an average representation of your methylation, but they weren't going base pair by base pair and actually sequencing this the way we would sequence the genome.
So that's inaccurate. So that is what's happening now. And again, to Peter's credit, he said to his knowledge. So I'm updating that knowledge base right now.
So again, it's so much noise in this system. And I just think it creates a little bit of a distraction for people, truthfully.
Do you avoid going through the...
All right. So if let's say Peter, if I'm listening to this 2 years ago, I would completely agree that it's mainly a distraction. This is how I looked at biologic age test 2 years ago. It's not useful to me. I mean, if you're chronologically 40 and it comes back you're biologically 36 or 44, I'm going to try to optimize you either way. Things have changed. And that's, I would love to have a nuanced discussion. We put out kind of a longer podcast back a year ago when Peter wrote an article about biologic age test, just going point by point and pointing out how, look, Peter, you're totally right. This is accurate a few years ago, but here's new and updated information. We really should be talking about the new information, not the old information. We don't want to bash cholesterol because the old way of testing isn't good. We want to talk about the newer and better way to do it because having these markers is useful. Is it predictive of your lifespan? Peter says the gold standard. The newer ones are. They're more predictive than chronological age. I want more than that as a clinician. I want to be able to follow things. And so, like what I use specifically, my favorite test is the pace of aging. It doesn't give you a number for your age, but it gives you your pace of aging, which I care about more. The number itself is a lot of that has to do with what happened in the past. Like Andrew was talking about in his 20s, working 80 hours. He did a fair amount of damage. He worked so hard. So I would predict it. Andrew has a much better lifestyle now. So his biologic age may reflect some of the bad tendencies of the past versus the good ones now, but his pace of aging is reflecting what he's doing right now. This DunedinPACE developed by Duke, for example, what I really like about it is it's got the really tight interclass correlations. It's very precise, like I mentioned. It also is very sensitive to change. And so as a clinician, I can do interventions and see how that changes it. It's been proven, for example, when you get pregnant, that's a physiologic stress. Your rate of aging goes up about 20%. Then it comes back down when you deliver. Same thing if you have hip surgery, you're in a car accident, you get COVID, your rate of aging goes up, and then it comes back down. So being sensitive to change, I want to see that if I'm going to try interventions and see how it's affected. There was a big study that Stanford did, a twin study looking at vegan versus omnivore diets. Lots of problems with the study, which we're not going to go into because we've talked about that ad nauseum on another podcast. But they use this pace of aging to see if they can find a difference in pace of aging, which is a nice integrator of everything you're doing over an 8-week period. And you can see the differences. So that's why I like the pace of aging better than other biologic age tests. If you're doing a biologic age and you're getting an age, if it tells you you're 30 years younger than your chronological age, it's probably not a good test. But again, the same things apply. Is it better predictive of lifespan? Is it going to be sensitive to intervention? And also, is it predictive of other diseases? So the reason we care about age is because it's the number one risk factor for all chronic disease. So these measures of biologic age, they also should be somewhat predictive. And you can look at things like epigenetics and PACE, and they do have really nice hazard ratios when it comes to predicting your risk for these other diseases. So I measure any biomarker because I want to know how that affects your risk for a disease. A biomarker doesn't diagnose a disease. You take your pretest probability, you add the result, and with a positive predictive value, negative predictive value based on that biomarkers, and then you get a chance of having a disease or in some cases developing a disease. That's what these are useful for. And the newer, better ones, the brand new ones, are good at that. They're good for a lot of things. So in conclusion, I would love to just have a more nuanced discussion around biologic age tests, not lump them all together because the first generation ones weren't any good. And because there's a lot of trash out there that take into all these variables, have so much noise. We need to be talking about not the ones that don't work. That's old news. We need to be talking about the ones that do work. So Dr. Tia, Dr. Eupin, would love to have that discussion with you. Thank you for putting out incredible educational material. I'm going to continue listening. If anybody's listening to this and they didn't listen to this conversation, you should, because there's so much gold in there, so many nuggets. But I'd love to have that discussion. So let us know if you want to have that discussion. Otherwise, if you're listening to this, hopefully it was helpful.